Venous thromboembolism, or VTE, is a condition where a blood clot forms in a deep vein and potentially travels to the lungs. It is the third most common cause of acute cardiovascular death worldwide. Treating these clots require navigating a very narrow therapeutic window. If the dose of blood thinner is too low, the clot continues to grow. If the dose is too high, the patient can suffer severe internal bleeding. Every treatment protocol for VTE aims to keep patients balanced perfectly on this physiological edge. Today, the standard of care relies on direct oral anticoagulants, or DOACs. These are targeted medications that thin the blood by blocking specific clotting proteins, largely replacing older, harder-to-manage vitamin K antagonists. The two most popular DOACs are Apixaban and Rivaroxaban. But despite millions of prescriptions, these two medications had never been tested directly against each other in a head-to-head clinical trial. Without that comparative data, clinical practice guidelines treat the two drugs as equals. Doctors have had to choose between them without empirical evidence to suggest which one is actually safer. To solve this, researchers launched the COBRRA trial. They took 2,760 eligible patients with acute VTE and randomly assigned them to receive either Apixaban or Rivaroxaban for a 3-month monitoring period. By directly pitting the medications against each other, the trial was designed to give prescribers the definitive data they had been missing. The dosing protocol for Apixaban starts with 10 milligrams twice daily, dropping after 7 days to a 5 milligram maintenance dose. Rivaroxaban requires a heavier loading phase, 15 milligrams twice daily for a full 21 days, before switching to a 20 milligram daily maintenance dose. To see if these different schedules affected the primary job of the medication, researchers tracked a secondary outcome: how well each drug prevented a recurrent symptomatic VTE. This chart shows the rate of recurrent blood clots over the 90-day trial. The two lines are virtually indistinguishable. Recurrent symptomatic VTE occurred in roughly 1% of patients in both groups. Measured strictly by their ability to stop blood clots from reforming, Apixaban and Rivaroxaban perform identically. The true differentiator emerged in the trial's primary outcome: clinically relevant bleeding. This metric combines major, life-threatening hemorrhages with clinically relevant non-major bleeds that still require medical intervention. This chart shows the cumulative incidence of bleeding events. Unlike efficacy, the two drugs' safety profiles diverge almost immediately. By the 3-month mark, 3.3% of the Apixaban group suffered a bleeding event, compared to 7.1% for Rivaroxaban. The gap is even more pronounced when isolating the most severe outcomes. Major bleeding occurred in 2.4% of Rivaroxaban patients, but only 0.4% of those taking Apixaban. Looking at the horizontal axis reveals exactly when this gap opens up. The starkest difference in bleeding occurs rapidly over the first 3 weeks. This 21-day window maps perfectly onto Rivaroxaban's loading phase, when the dose is 50% higher than maintenance. Apixaban, on the other hand, steps down to its lower maintenance dose after just 7 days, resulting in a much flatter trajectory for bleeding events. While not explicitly proving causality, the data shape strongly ties Rivaroxaban's extended 3-week loading dose to a higher early bleeding risk. The data also presented a counterintuitive detail regarding patient behavior. Based on self-reporting, medication adherence was actually higher in the Rivaroxaban group, 75.1% compared to 65.7% for Apixaban. However, this stricter adherence to the Rivaroxaban schedule did not lead to better clot prevention. Instead, it correlated with higher rates of specific bleeding events, particularly vaginal and gastrointestinal bleeds. It is also important to note who was left out of the trial. Following the clinical guidelines established at the time of the study's design, patients weighing over 120 kilograms were excluded. Patients with active cancer-associated thrombosis were also excluded, as the efficacy of these specific drugs for that population is evaluated in completely separate clinical trials. So while the COBRRA trial clarifies the picture for the general population, physicians treating complex edge cases must still rely on specialized clinical data. For the standard patient, the conclusion of the COBRRA trial is unambiguous. Apixaban carries a significantly lower risk of clinically relevant bleeding than Rivaroxaban. And it achieves this superior safety profile without sacrificing any of its effectiveness in preventing recurrent blood clots. By directly comparing these two medications, researchers have closed a major gap in the clinical guidelines, giving prescribers the clear evidence they need to make a safer, more confident choice for their patients.